Okay, so first I want to thank you all for allowing me to be here and talk and to be part of this. And thank you so much for the patience of getting this all set up. I know it's definitely difficult to connect with a different country, and I appreciate the opportunity of me being here to have this conversation and just share some about the program and the things that we have happening here in Shaker Heights in Ohio. So my name is Annette Amistadi. I am a licensed clinical social worker. And in Ohio, we just call it licensed independent social worker. I have my master's degree here, and I work in Cleveland, Ohio, and just a suburb of Shaker Heights. And I am here to talk about the mental health response program. That is a pilot program that started in January of 2022. And this program really was developed because the city identified the need of having a mental health professional embedded in their police and fire department. The city was able to look at that, come together and make a plan. And from there, that is how I ended up being here. So the program itself has goals and why it was designed. And one of those was to provide a little bit of that virtual co-response. So co-response meaning being with the police department and the fire department. So you're actually going on scene. So the first goal was to be able to have a virtual component. And we do that by the EMS, the trucks, they have like technology that they're able to call and do like face-to-face like Zoom videos with the patient that's with the fire department. And then also the police have their phones and we're able to FaceTime. And so the first goal was to really start working on that virtual response, that if I couldn't be there in person, we're still able to be there in another weird kind of way. And so that was the first goal of this program, was really to figure that out and to help address that barrier of having someone on site and being able to have just another option for follow-up care. Because they were already doing that, you know, the fire and EMS and paramedics were already doing that with the hospital. So it was just adding another layer there of availability. The next goal that we have is for me to be able, or the clinician that's on scene or virtual, to be able to offer de-escalation strategies, crisis stabilization, provide assessments, and make referrals in real time. And that's a big one that we've really been focusing on. Is the de-escalation is definitely huge. I know the police and fire, they do an absolutely amazing job, but as a mental health professional, we bring a different understanding and scope of practice into that. And so that was the second really big main point. And then the other one that's really big that we really focus on is the referrals and addressing what that person needs, that they're in a crisis, and really addressing that maybe they're calling 911, but in all reality, they need something else. And so that's the other part too, is really providing those referrals online or on time. So that was the second big one. The other one is doing follow-up calls. So doing follow-up on calls to help ensure the residents of Shaker Heights are connected to services and not experience future crises. So, you know, that's a big one that we really focus on. How do we do that? And the follow-up, and people may or may not want to follow up and kind of those things, because I'll talk a little bit later about our shifts, but I'm not here all the time. And so how do we make that follow-up when we're not on scene? And so that was the next step, or the next big point that we had. And then the next big bullet point of the goal for the program was to the offering outreach, prevention, and early intervention to community residents and families who may not have a crisis, but are referred by the police and fire department as potentially needing assistance and services. And that goal for the program was really developed because when the police and fire may be there, it's not really a crisis, but that person doesn't know who else to call. And so how do we help the residents prevent a future crisis and prevent something that's going to become very big, very intense if we can avoid it in the future. And then other things, the police and fire department get calls, not to the emergency line, just asking questions about certain resources, or even city officials get calls. And so we're able to follow up on those to help prevent any future crises. And then the last goal of the program was to connect people to services, reducing calls to 911, and preventing future crisis. I mean, that's really the big overall goal, is to connect people to the actual services that they need, and allowing them to have a resource instead of calling emergency services. And so that really encompasses all of the other ones, and that's the biggest one that we have. And so the city recognized those goals, and then here I am. And from there, it really looked at how do we develop that, and then also what comes next. So the first one that we really looked at is, how do we know someone needs a mental health kind of response, and that care response instead of a police and fire response? So that's something that we're still working on, because we all know that a crisis for somebody, it looks so different. And we all define crisis different. And from a social worker perspective, to me, I look at the whole picture, the whole scope of practice of what that person needs. And so we don't address the silo. If someone's calling 911, but maybe they need housing, maybe they need food, and they don't have insurance and all these other things. And so that's something we're really working on, and not trying to put things in a big, very tight scope of just saying a mental health crisis. We open that up to say something that someone needs, that support system. Sometimes we have failure to thrive, but maybe someone who's living in their apartment that is maybe at an age that they're not able to take care of themselves, that's a referral for me, because it's not necessarily a crisis, but they're really getting into that area that they're not able to take care of themselves. And so that's something where that education, where we had to step back and look as to what actually constitutes as a social worker being involved. And it really opened it up to not just be a mental health crisis. And so that was really the criteria. We're really working on narrowing it down. I wish I had a more narrow criteria really to share, but we really don't. And we go off of what we feel would be helpful by me being there. And we're catching it, we're learning. Those things that are obvious, if someone mentions a call to dispatch that they have a mental health diagnosis, or there's potential suicide or overdose or things like that. Like that one is the simple, I don't want to say simple, but that one in regards to criteria, that's an easy one for us to say, yes, that's a criteria. And so we're really working on the other stuff that we're looking at the whole picture of the individual, and not just they're in a mental health crisis, the whole picture. And so when I'm in the city, that is where I actually listen to dispatch, and I listen to the calls coming in, and I can give feedback as to, hey, I want to go on that call. Or when the police and fire actually show up on scene, that's where they're like, hey, can someone go get Annette? And someone comes and gets me, because I don't get my own car. That'd be really cool. I don't think they trust me to drive the police cars yet, but that'd be fun. Someday we might get there. That's something we're exploring as well, of looking at those models. But for right now, they come and get me and they drive me where I need to be. So that's kind of where we narrowed it down, of looking at, okay, well, who kind of would benefit from that? And we're kind of finding that, in my opinion, everybody can benefit from a little resource, or just, a teenager who's really giving their parents a hard time, and kind of being there for the parents, of being like, you're doing a great job. I know that teenager doesn't want to go to school and they're really giving you a hard time, but you're doing a great job. You're doing all the right things. So sometimes just having that there. And so we really just haven't really made a really narrow criteria yet. And then it goes into the shifts. So right now, due to some staffing challenges, that's definitely something we're really struggling with, is finding someone who is qualified to do the work, which I'll go into training next. And so ideally our shift is from about 10 a.m. to 6 or 8 p.m. That's really what we're looking for, is a little bit of that first shift, with second shift and catching those who we're trying to catch the most amount of people, and having some weekend availability there, because we can't predict a crisis. And right now we don't have 24-hour service. I have that virtual option that if I'm not here, but during those hours, they're able to call me. That's something that we're working on. We're trying to get a full-time person, because right now I'm the only one covering it. So I'm in the city 2 days a week and do as much as I can for those 2 days. And so we're really working on that. We're really developing that. We're trying. It's just we're really experiencing a staffing shortage, and it's something that is just taking us some time to really work through and figure that out. But hopefully soon, fingers crossed, we get that kind of narrowed down a little bit more. But for right now, I'm going to continue covering it and being the manager of the program. And one of those criteria as to why it's so hard to staff is just because of training that we're really looking for, and also the knowledge base. Being okay at de-escalation, that's not something everybody's born with. Not everybody's okay with walking into maybe someone very upset or crying or have just gone through a very traumatic event. And so that's something that experience, and sometimes people are naturally good at it. I've learned that, and sometimes experience is needed. So we're really looking for somebody who has that de-escalation, kind of a good foundation. And then from training purposes, we provide more training. Mental health first aid is a huge one for us. And then also knowledge of resources, because when we're on scene, I don't know everything, because Google is my best friend. I don't know if anybody else uses Google, but Google's my best friend. And so I just need to have the knowledge base of the resources. And then from there, I can get those really narrow, or those more defined results of what I need in regards to phone numbers or addresses, things like that. But those are like the basic of the training that we give, and then looking forward to provide to future staff and things like that, and that I've received. The other part of training that is something I'm learning, as this is new to us, is understanding the protocols and the training that the police and fire actually go through. That is something that there's no class in schools that's like, hey, if you're going to work with police, you need to know these things. Or at least I haven't got it, right? Where of how to learn their language and how to understand the different pieces of that. And because for me as a social worker, I'll go up and knock on anybody's door. It's fine, right? I'll do it. I'm just walking up there and they're like, where are you going? I'm like, what do you mean? We're here for welfare check. They're like, you have to take safety first. I'm like, oh, okay. Like, so that is something that has been so new to me in understanding that. And so I had to step back again, as this program is really developed, to really understand the protocols and the policies that they have. And then also working with them to maybe change that when I'm on scene, or to change that when there's a different resource for them. And that's been huge, again, of just understanding that, because we talk such a different language. And it's interesting, of understanding that. I have a little bit of a step up, I guess, because I've been in the Army National Guard here in Ohio for 14 years. So I sort of understand protocols of that. I kind of get that, which has helped me. But when we look at training, of really understanding that, and times, going to military time or the 24-hour time, those kind of things, not everybody knows. And so that's something that we're looking for training as well. And then also the other part of training is just different codes for things, and understanding the actual dispatch criteria, what dispatch understands, because that's something that we're really looking at here in Ohio and across the country, of how do we intervene earlier at dispatch to understand who's the right person to go. So understanding dispatch and what that looks like. Because again, as a social worker, I was never exposed to that. And so that's been very exciting to understand those things in that process when it goes to training. And it's something that I'm really learning. And it's taking time. And that's something I think is going to continue to develop, especially as we're seeing the states at our local levels and at the big level. We're really looking at that. And how do we do that? And how do we support the mental health professional actually doing the work and giving them what they need? It's something that we're all catching up on, and to address the big need that we have. And so, then I look at, some other just things that I might do. I thought I'd provide some examples here of what I really do on a day-to-day basis when I'm here. Responding to calls is my main priority, is to respond if there's a crisis in the moment. I'm going to go and be available to them in that moment as a resource to the resident and the police and fire departments. And then the other part is follow-up. I have individuals that I've been working with for months. It's not a crisis now, but I'm building that rapport and addressing those behaviors and things like that to maybe get them take that next step that they really might need. Hoarding is something that's really big here in the city, and that's a tough one. A hoarding disorder is something that it crosses lots of lines, where it's a safety issue from the housing department in the city. It's the other part of the ordinances of the fire department, the housing code, and all of those things. And then there's me that's like, well, if they're not a risk themselves or others, I can't do anything. And so it's really interesting how we come together. And so I've been following with one individual every week. And I talk to her, and we talk about little things that she could maybe do or throw away that day, in the hopes that someday she would be willing to go into treatment or see that's even a problem for her. She doesn't see it as a problem, and get some treatment and get some help. But for right now, her talking to me, I love it. If I can get that, she looks forward to it. We have conversations. We talk about other things around it, the anxiety and going to her doctor's appointment, and addressing those other barriers that she has. So someday we might be able to address the actual big issue that's really contributing to those other problems that she's having. But for right now, that's okay. There's other individuals that I follow up on that maybe have moved out of the city, but they had a crisis when they were in the city. So I still provide a little bit of guidance to them, a little bit of resource help, do those in phone calls. And then after I call them my frequent callers, just because, my regular clients that I talk to are individuals that I talk to. And then outside of that, I follow up on calls. So once the fire department and the police department, they get that consent, they pass that information to me, and I follow up on them because I'm not here all the time. And so those calls, I give a phone call to the number on record, and then I try to do either I try to do what I can over the phone, but I don't always get the best response over the phone. And so I then compile all my stuff together, and whatever officer is able to do that with me that day, they go out with me and they drive me around, and I do my knocking on the doors. I do my outreach that way. And that's what the day normally looks like. And then I always think it's important to, look at, sometimes I get a good response. Sometimes I don't. Sometimes people, the crisis is over and they don't need anything else, which is totally fine. Sometimes it's a longer term. Sometimes it's like, I don't want to talk to you. There's still that stigma in regards to mental health care, and a social worker, especially if it was maybe a child who was having an incident and they called 911, because there's that stigma that I'm going to come in and take their kid. And so it's addressing some of those barriers and me being aware of those, and how do I work with the individual on that barrier. And so that's what my day-to-day normally looks like when I'm here in the city, as well as any virtual calls. If there's something that maybe I'm at my other office doing things and there's something going on, they give me a call as that virtual piece that I talked about of our goals. And I address some scenarios, or I go over resources with an individual. I de-escalate over the phone. I've had instances where that individual wasn't trusting of the fire department or the EMS squad that was there. And they called me like, hey, can you talk to her? Because she needs to go to the hospital. She says she wants to go, but she won't get in. And so I talked to her and I stayed on the phone with her, and I was able to go through that with her. And how do we do that? and kind of navigating that mistrust with her and those barriers to get her the help that she ultimately needed. That was by virtual, that was by phone. And so that's typically what it looks like for me throughout kind of the week and the days that I'm here. It keeps me busy. Some days are busier than others, just with calls in regards to crisis, and some days it's busier than others just with follow-up. It looks so different, again, because we're not really looking at just mental health crisis. We really are looking at the needs of the city as a person as a whole, and that person-centered approach. I'm really looking at that and not just addressing kind of that crisis. I'm just going to make sure I covered everything. The other part that I think was on here is just lessons learned. You know, I think that's something that I've learned a lot. I learned a lot about me as a person. I learned that I'm pretty good at de-escalation. I'm pretty comfortable with it. For some odd reason, I don't know, it all works out in my favor. I learned that I knew the need was there, because I think that's why I wanted to manage this program and to help with this. But it was really learning about the calls that really come into 911. I wouldn't think of someone calling 911 because their fries at the fast food restaurant were cold and they wouldn't give them a new one, right? I wouldn't think people would call emergency services for that, but that's a thing. But that person still has maybe another support system that they might need. It's more than just the fries, right? So there's more. And I didn't know that. And so lessons learned was me understanding a little bit more of the population in regards to who calls, what kind of calls do they get, what people don't call, and when it's too late for things, or then it gets too bad. You know, I've also learned a lot about the protocols and policies. I know I said that earlier in regards to training. I've learned so much. There's just a different mindset that we all have. Because I come from the mental health scope, and then police have to come from theirs, and then fire comes from theirs, and then every individual, right? And they all have different training. And I've learned that there's just a gap there. And so lesson learned is to learn how to address that gap, which is something this department has been amazing at helping me understand and having honest conversations about it. And so that's the other part of that lesson, is to have the buy-in, I guess, of the people I'm really working with. Because without that, I think that would have been a huge challenge. But the city itself, the police, every person that I've had any contact with has been absolutely amazing of, again, me learning things. I have a silly example, but it's huge. I didn't understand. So I was riding with the police, and I shut the door of the car, the cruiser that I was in, and apparently I slammed it. I didn't think I slammed it. And he's like, hey, you have to pay attention not to slam car doors, because that's their training. And I was like, oh, okay. Because again, that social worker in me, I'll knock on anybody's door. I'm going in. It's fine, right? Like, that was a huge lesson learned of me understanding that. And again, the amazing individuals that I work with here in the city, and both the emergency responses, because they have been absolutely amazing being patient with me and understanding that process. So it's been absolutely amazing. Other lessons learned is the need for us as a mental health profession to really look at what this means for us. I think sometimes we forget about ourselves, and because we're always caring for somebody else. I think that's a huge lesson that I learned of how do we support one another as a community, because right now it feels that we're all trying to figure it out, which is amazing, because that's what we're here to do. That's what social workers do. We're here to figure it out. But we have to find a way to make sure we support and give the training that we actually need. Because yeah, de-escalation is wonderful. There's so many trainings out there. Totally agree. But it's different when you're working with a police officer and doing that. And it's different when you're working with a firefighter when you're doing that. Even the care models that have the social worker and a paramedic just responding, that's still a team that you have to figure out. We need more training and support on that. That's a lesson that I've learned in working with the team here for me to understand that. But I think as a whole, that's a lesson learned of how do I help with that for the future, because this is something that we're changing here, and I want to be able to be a part of that. Other lessons learned I think we already know is that not everybody wants my help. Not everybody wants my wonderful resources and wonderful things that I have, even though I think they need it. It's just been very interesting. I already knew that as a clinical person, I knew that, but that doesn't mean it gets any easier as I'm responding on that call in the moment, in the emergency. It's just like, hey, I've got this for you. Like, this is a one way, so you do not have to do this anymore, right? I can give you that resource, and they don't want it. And that's hard, you know, in that moment crisis to give something and then also be like, okay. So that's something I've learned a lot too. We can have every resource available, but that right to self-determination is huge. And it's even just more prominent as I've gotten into this kind of work in that moment crisis. So I think I'm having 20 minutes. I think I'm there. So I'm good. Okay, good. I think I've addressed everything. So good to